will today. So Dr. Gottlieb, thank you so much for being with us.
It's a pleasure. It's a pleasure. Thank you. Can you hear me okay? Yeah, good. So just a quick story before I get started. I was giving a talk a couple of years ago, and I heard a cell phone ringing. And my first reaction was, I felt bad, you know, a person's going to be embarrassed. But it kept ringing, and it was getting on my nerves, you know, thinking, pick up the phone already. Meanwhile, it was my phone. And it was my daughter calling to ask how the speech went. I said, I'll keep you posted. So, growing up, the mantra I heard was, as long as you have your health, as long as you have your health, you can't be happy if you don't have your health. Well, I'm here to tell you, after 42 years as a quadriplegic, my health is for crap. And it's getting worse. It's so bad, I tried to get a timeshare in the hospital. But I'm happy. More important, I'm grateful. So how does it happen? We go from despair, maybe depression, to well-being, and even gratitude. Well, it doesn't happen right away. And it can take years. So let's start at the beginning, the diagnosis. We see the first symptoms, and we try to ignore it. We see an unsteady gait, and we tell ourselves, it's a bad day, or it won't be here tomorrow, or it's not that big a deal. And the anxiety we feel gets buried inside. And like a colleague of mine once said, all buried emotions are buried alive. They're in there. And then the symptom gets worse, or we see a second symptom, maybe impairment of vision or hearing, and we can't deny it anymore. So with all our anxiety and fear, we go to the doctor, and we hear the dreaded words, Friedreich's ataxia. When I had my accident, it was on the Pennsylvania Turnpike, and I was going westbound, the truck was going eastbound, and he lost his whole wheel, not just the tire, but the metal wheel. And it bounced across the turnpike and crushed my car and broke my neck. I didn't see it all unfolding. The last thing I saw was a black thing, and it looked like it was just a few feet from the windshield. So I was hit by a black thing. Probably everybody in this room has been hit by a black thing. So what follows in the aftermath of this dreaded diagnosis or accident? For me, it was terror about the future. No sadness, no grief, just terror and rage. You wonder, why rage? Well, I consider rage a judicial emotion. Rage is a reaction to injustice. And we have all experienced injustice. Whether you have Friedreich's ataxia or love someone who has it, you've experienced not just a loss, but the experience, the internal experience, is that of a theft. Something was stolen from us. We don't have anybody to blame, although if you're like me, you look for someone to blame. It's a theft. So what's been stolen? Well, our bodily functions, our independence, our sense of fitting in with others, our sense of being like the other kids. Something we want from, what, second grade on. We want to be like the other kids. And we were robbed of our dreams for the future, all stolen. When I was in the hospital, it seemed that every day somebody came in and told me something else I would have to live without, that I'd never walk again, or certain bodily functions I'd lose control over. Every single day. And then one day, this is after I'd been in the hospital a few days, one day a nurse comes, I had a full beard at the time. One day a nurse comes in with a shaving kit, the day before surgery, my fusion surgery. I said, what's that for? She said, well, you're having surgery tomorrow, and we're going in through your neck, so we have to shave your beard. I said, that's not going to happen. I said, I've lost enough. You're not taking my damn beard. Only thing I felt I had control over. So she contacted her supervisor. Supervisor didn't make any progress either. The head of nursing, they called her at home. They wound up shaving just a quarter of my beard. I was out of control in a literal sense. And we are not good at it, at being out of control. Of course, the twin of rage is self-pity. We can't not have some self-pity. I remember I was in rehab, and I was looking at the windows. It was McGee Rehab, which is 15th, 16th, and Race. And I was looking at the window out onto Race Street. It was winter, and there was a man laying on a grate, homeless man. And I looked at him and I said, well, at least he could get up and walk away. And I realized, my God, I felt envy of somebody who had no home. That's how low I was. Self-pity. It's poison. We're dumping poison into our body. What restores it? Self-compassion. Not self-absorption, not narcissism. Self-compassion. Kindness. Kindness towards this good person who suffers. This person who at every turn in their lives tried to do the right thing. Successful or not, this good person who suffers. That's self-compassion. Self-worth. Society tells us we should be something we can never be again. I remember I was invited to give a talk to a group of physicians, and I'm in the back of the auditorium. They're not seeing me there. And they're talking about how to give their patients bad news. And a urologist raised his hand and he said, "Tell me, how can I tell my patients with spinal cord injuries that they're now half a man?" And I'm listening, and I'm thinking, damn, I wish I could empty my catheter bag on his foot. Oh, but I didn't. Those are the stereotypes we live with, huh? You have an unsteady gait. People think you're either drunk or you're intellectually impaired, or both. Same with people in wheelchairs. My daughter, she was about 6 or 7 years old. We went out to a diner for lunch, and the hostess says to my daughter, "Where would he like to sit?" And I said to my daughter, "Tell her I'd like to sit over there." What we live with. Nevertheless, I didn't feel useless and worthless. I knew I was useless and worthless. I was a burden to my family, and I would be for the rest of my life. In a very real way, all that anger I felt, I turned towards myself. I hated my body because my body betrayed me. I hated my life, and I hated myself. Yes, I was depressed and struggled to get out of bed every day. Every day I wanted to stay in bed because I didn't want to face another day of quadriplegia. And yes, I didn't think I wanted to live. And believe it or not, what I was experiencing was not a clinical depression. We used to call PTSD a normal reaction to an abnormal situation. That's what I experienced, a normal reaction to an abnormal situation. You too. It's called reactive depression, or technically, it's an adjustment disorder. When you think about it, that's what we're doing. Right? We're trying to adjust to something that is really out of the ordinary. What happens when we experience a divorce or sudden death of a loved one or life-altering diagnosis? And generally, talking about it with someone who loves you, who understands, who wants to understand, or talking with kindred spirits like what we're doing right here these last couple of days. That helps. Meditation helps, yoga helps, exercise helps. And it usually passes in time. If it does not, then it's likely a major depression, a clinical depression. So how I said it was a struggle to get out of bed every day, but I did. I was afraid to stay in bed for even one day for fear I'd never get out again. So I got out. Major depression. I would have stayed in bed and not gotten out. It involves changes in sleeping, in eating, socializing. We withdraw. Increased anxiety, apathy, excessive guilt. Those are all symptoms of a major depression. And that needs intervention. It needs help. Therapy, medication, whatever. We call this psychopathology. I challenge that because psychopathology implies there is pathology in your psyche. There's not. There's pathology in the world around you. There's pathology in what you have to live with. But there's not pathology in your mind. Most of you have read, I imagine, about the mental health crisis in this country, especially with our children. So in 2020, before COVID, right before COVID, there was a survey done, and 10% of all children were diagnosed with an anxiety disorder. 5% were diagnosed with depression. Those are big numbers. After COVID, 25% of all children in this country have a mental health diagnosis. And God, I wish there was treatment available for all of them, but there's not. Children with disability, they have between 2 and 10 times the chances of developing a mental health problem. So let's take a look at this. We lost our health. We lost our vision of the future. We often lost our faith. But to me, the most painful is we lost our sense of belonging. We lost our sense of being part of the herd, for lack of a better word. You know, I looked around my hospital room and I watched people. They were walking and talking and holding things in their hands. I thought, I can't do that. Am I still one of them? I felt I'd lost my humanity. I was no longer like all other humans. I've never experienced anything that painful in my life, that dangerous, that lethal as loneliness, that kind of loneliness. Watching that, feeling that, I wanted to give up. Couldn't live with it. Loneliness is lethal. The American Cancer Society took a look at the impact of loneliness across races and genders. Adults who were lonely had a 30% increase in risk of stroke with the development of coronary artery disease, 40% increase in a person's risk for dementia. Loneliness is as toxic as a pack of cigarettes a day. And what makes it worse is the shame that goes with it. Embarrassment. That causes further withdrawal. So, here we are, at that point. And at some level, we ask ourselves, okay, what now? And everything changes. Because at some level, we're saying to ourselves, all right, this is what I have to live with. Now the question is, how am I going to live with it? I hear that in my office almost every day. I don't know how I'm going to live with this. I said, give it time and look back in the rearview mirror, and then you'll have your answer. Because we do. We do. We find a way to live with what we have. We pursue life. I told my family that I'd give it 3 years, and then I would decide whether to go on or not. And at the end of 3 years, I took myself into my room, and I thought about it. Do I want to go on? And I negotiated with, I don't know, my higher power, my inner truth, and I said, okay, give me hope that I'll walk again. And the voice back says, no hope, live or die. And I said, then give me hope that I won't be so sick. No hope, live or die. It's a hard bargain. Well, it's no secret what I chose. And why? I said I did it for my daughters, or my wife, or my parents, or my patients. There's some truth in all of that. But the real reason I did it was I chose life because I wanted to live. Sitting out on my deck a couple of years ago, I looked over it. I've got a bank of windows, and under it, from the window to the floor is stucco. And I looked over, and I see in between the window and the stucco, there's a leaf. And I figured it was a dead leaf that got stuck there, so I went over to brush it off. It wasn't a dead leaf. It was a live piece of ivy. It was on the other side of the wall. That ivy found a crack in the wall and dug through insulation, found a tiny hole in the stucco, and found its way to the light. All living things pursue life. What now? We pursue life. After my accident, right after, as they were pulling me out of the car, the last thing I remember is saying, call everybody I know to get here right away. Somehow in my delirium, because I don't remember the next 36 hours, just in that moment, I knew I needed the loving care of others to survive this. We all do. We can't do this thing alone. Teddy Pendergrass was a R&B singer in the 80s. He was world famous. Had an accident, became a quadriplegic, and wound up seeing me. I can talk about it with his permission, and he wrote about our experience together. He was suicidal. And I worked with him for, I don't know, months, 6 weeks, 2 months. And he made up his mind. He was going to die. So he's leaving my office, and he gets to the door, and he turns around, and he said, well, I guess I won't see you again. And I said, you guess you won't see me again? Told me he was ambivalent. Brought him back in the office. Next session, I brought him back in the office. I brought his family in, his son, his wife, and his mother. And we talked about possibly losing him. And I told him my recommendation that if he wanted to die, let's see what it's like dying. So I had him call everybody in the support network to come to his house at a certain day. I said the same to his mother, his wife, and his son. I went to his house, had to be 120 people there. We put a sheet over him so we couldn't see. And we had people one by one coming up to him, to his grave, and saying what he meant to them, one by one by one. And after 5 minutes, probably less than that, he wanted the sheet off his head, and he wanted to live. Why? The loving care of others. The loving care of others. One of the things we do, I talked about shame, is we withdraw. It's our instinct when we feel shame, right? We hide it, we bury it, we pretend it's not there, we lie about it. We keep it buried inside, and shame is like mold. It grows in the dark, it festers, it can become lethal. And what kills mold? Sunshine. Counterintuitive. We open up what we're ashamed of. I had a young lady in my office, 17-year-old girl, and she was beating herself up for, I don't remember, pimples or weight or whatever it was. Of course, like most 17-year-old kids, she was beautiful in her own way. And it was hard to listen to it. And, you know, I know better than to try to talk her out of it or challenge her. But it was hard to listen. And I bent my head down at one point. And when I did, I saw that my catheter had leaked and my pants were soaked. And I was almost too ashamed to raise my head back up. I was that embarrassed. And finally I did, and she saw what was going on, and I didn't have language. I didn't have a word I could use to say. She stood up without saying a word and came over to me and put her arms around me, put my head on her chest, and we just held each other. Two vulnerable humans caring for each other, feeling compassion for each other, even loving each other. You know, there's a marquee on a church around the corner from me. It said, God is one. And in that moment, with that 17-year-old girl, that was divine. When we are that close to another human being, where our hearts are open, where we share our vulnerability, our most tender parts, that is divine. I don't know if many of you are familiar with a song from the show, Aspects of Love. But the lyrics of the song are, love changes everything. How we live, and how we die. And the more love we have in our lives, the happier we're going to be. It's just that simple. It's got nothing to do with how many people love you. It's how many people you love. That you have control over. And love is risky, and it's habit forming. Because the more you love, the more you love. The more you love, the easier it is to love. The less fearful of the risks. I encourage people to love who you love. And tomorrow, love them better. Love them deeper. Know how they hold their shoulders when they're tired. Watch how they breathe when they're stressed. Look at the color of their eyes. Love them that well. And then the next day, love somebody else that well. The more you love, the more well-being you'll find. Yeah, love changes everything. I jotted some notes down a few years ago about the experience. When life comes at you, bare-knuckled and bloodthirsty, and rips away the sidewalk you had been walking on your whole life. So there you are, lying naked and beaten in an unfamiliar land without any familiar guideposts. Beyond sadness, grief, and even loneliness, there's a feeling of isolation and inferiority towards the whole world. So you hide your anguish and shame, too scared to cry, because if you do, you might never stop. And everything you thought was true is now gone. So without a roadmap, you get up, frightened and fragile, you take your first tentative step into the unknown future. You go to doctors to heal your body, but the scars are permanent. You see other doctors to heal your broken heart, but those scars are permanent also. After the shock and anger and self-pity and resentment, when you are too exhausted to fight against the truth of your life, you finally cry oceans of tears. You cry for all you've lost, and you grieve for what you had been yesterday. And then you might feel compassion for this good person who suffers, and then perhaps compassion for all who suffers. And so it begins. It's different from before. You find yourself not as strong, not even strong enough to hide your own vulnerability. And then you notice the air itself smells sweeter and the sun brighter. Your love is less tentative and more generous. And you begin loving more people and more and all living things. And loving seems easier than it did before and more abundant than ever before. And you close your eyes and you hold your life before you. And it's only then that you realize all of this love comes through that scar tissue in your broken heart. Thank you, everybody. So do we have time for Q&A, or did I? We do. Comments, questions?
If there are people here who were removed from your speech, like I was, what would you say is the first step in trying to figure out the jumbled mess inside your head and your heart? How do we start down the road of sorting that out or addressing it at all?
One of my meditation teachers, Sylvia Borstein, wrote a book entitled "Don't Just Do Something, Sit There." Don't get so busy so fast. Feel what you feel. Let it be there. I get skin breakdown, and I learned from my doctor that wounds to the skin heal at a rate of 1 millimeter a day. And I wondered, when he told me that, what about wounds to the heart? How long does it take for that to heal? That's what's happening. I encourage you to have faith, open up, sit there, feel your life, and watch what happens. Don't rush to live with this better. Don't rush to be some kind of hero here. Just be who you are. One of my other teachers said, the world is full of people trying to be filet mignon, and deep down we know we're meatballs. So do what you do, but don't forget you're a meatball, man. Nothing personal. Anybody else?
I've got one.
Wait.
Thank you. First of all, that was very moving. Appreciate that. So you said something that resonated with me. I have 2 children that suffer from this. I have loved ones in this room that suffer from this, who I consider my children as well. When that woman, that young woman, you said you were speaking with her, you weren't going to talk her out of the way she felt. You're right. You're not going to talk them out the way they feel, because you're just not. What other things can you do for people like myself who are caregivers, who love these people? What other things can we do that would really show that type of support, besides all the great things we do already? As a professional, what other things would you suggest?
The hunger to be known exceeds the hunger to be loved. That's what we want. That's what you and I want. We want somebody to know how we experience this life of ours. So your job is a very, very difficult one, is to sit with someone you love in all your helplessness and listen to their suffering. Your job is to tolerate your own helplessness. That's a hell of a job, you know? I wish it was easier for all of us, but that's a great act of love, is to tolerate your helplessness. With everybody, not just your kids, you know?
Okay. So, thank you for speaking. I'm very vocal about the feelings I'm having with all this. Some people in the community know, some don't. So, going off the question about caregivers loving and being there, supporting their family members or their friends with this disability or disease, how does the community as a whole, how do we open dialogue to have the tough conversations about when someone's struggling? what resources can FARA provide to a family?
You're asking what resources does FARA have?
Yeah.
I
or
don't-
What's out there that FARA could direct a family or even the community as a whole to be like, there's these sources to use to help you understand or deal or cope with the world. Because right now it's a terrifying place for everyone, but especially the disabled community.
What do you need?
From my experience, the world, I have come to see it in a different point of view. And when I try to reiterate it to my family members, they don't get it. And that aspect, I guess, of it all, of having these two point of perspectives or point of views is something that I think the community as a whole, we kind of need to open that discussion or dialogue or door to be like, everyone's going to have a different point of view because the disease affects everyone differently. But if we just take this step forward to be like, let's have these conversations, I think you have touched on everything that I have been feeling for the past almost 9 years since being diagnosed. And sorry,
What a gift for both of us.
it's
You'll note that in my comments, I didn't talk much about symptoms or the physiology I talked about our internal life. You say people don't get it? Well, they don't, they can't. But they can get a sense of helplessness and vulnerability and fear, and they can get that. And if we can have the courage to talk about our internal lives, Brene Brown says that courage comes from the root of courage is C-U-R, heart. So courage is to speak from the heart. So if we can be courageous enough to speak from the heart, people will get that.
thank you.
Up front.
Thank you. I feel very grateful that you're here today.
Bless your heart. you get to hug her down there. I'm a little jealous. Anybody else? Well, that young lady thanked me. I want to thank you for being so open, for coming. It's good to be with kindred spirits. So thank you, everyone.
Let's give ourselves a few minutes. And whatever we need for ourselves. And then we are going to our breakout sessions. And there are 3 of them. We'll have folks out in the hallway to help you figure out which room you need to get to for each of the breakout sessions. And then after an hour in the breakout session, you can rotate to another one. So of the 3, you'll be able to go to 2. And then after the second breakout session, we're all going to come back here before we close the day. So Dr. Gottlieb, thank you so much for being with us today and sharing
pleasure.
with our community.
Will you take my microphone? Give it to someone.
Can you guys hear me? So I put it in the packet, which breakout is where, but in case you didn't see that. So in this room is taking control of your care. Across the hall is going to be emotional health awareness. And down this hall straight back and on the right is Haverford. And that is where one voice can create change is going to be.
wanted me to. Ooh. Hello. Ooh. All right, everyone. We've been asked to get started. And I realize not everyone may exactly be in the room for this session. You may just be left over from chatting and lunch. But we welcome you if that's your circumstance. I need the bell. Oh yeah, where's Jen with her? Or you know what? I had the Yipe family buzzers here earlier. We may need to get them back and just be really loud about it. All right. Thank you everyone for being here, whether you're here on purpose or you were sitting here when I started talking and you're like, well, I might as well stick around. No problem. So I'm Shana McCormick. You all heard from me earlier. I'm an endocrinologist at CHOP. You know, when we were talking about the title of this session, we're talking about healthcare transition and managing your medical care and independence. I'm going to offer, you thought this was a breakout session and I'm starting with slides, but I promise it's 3 slides, and I was asked to do it just to outline some of what I had envisioned we talk about. But what I'm outlining is just a starting place, because these panelists are incredible and have lots and lots of insights to share, and I imagine we'll get even more from the group that we have. So when we're talking about healthcare transition, I feel compelled to define it. So healthcare transition and definition from this website called gottransition.org, which is a government-supported initiative to address problems related to healthcare transition. So it's the process of moving from a child or family-centered model of healthcare to the adult model. And the goals of transition are to improve the ability of youth and young adults with and without special healthcare needs to manage their own healthcare and effectively use health services, and to ensure an organized process in pediatric and healthcare practice to facilitate transition. And in case there are any adults in the room who thought, oh, managing your healthcare sounded good, but this sounds pediatric focused, I would say this session may still be helpful to you, because as pediatric practitioners, we're aiming to get our young patients to a place where they feel a lot of self-efficacy as adults. And there may be adults who feel like they still need tips and strategies to achieve that self-efficacy, and we're going to be focusing a lot on that. So why do I care? There's a lot of data and increasing attention on healthcare transition, on moving from pediatric-focused care to adult-focused care, and how well folks do as adults managing their medical care. And the takeaway of all this research is that we do a terrible, terrible job of preparing individuals for transition. It's not my area of expertise, but as a clinician, I have to take ownership, right, of how well or how poorly we're doing. So there's missed opportunities for helping people thrive. This is a photo from the Olympics in 2012 of a legendary baton drop, and I feel like at the moment, a lot of pediatric practitioners are dropping the ball, dropping the baton in transitioning to adult care. So from a pediatric subspecialist perspective, we're supposed to hand off like the Jamaican women, right? We're supposed to develop educational guides, talk about which of our patients are approaching transition, assessing their readiness to transition, putting together all sorts of resources to help folks function independently. But and then follow up after the fact to say how well are people doing managing their care. And it turns out that all isn't really happening the way it could. So for this panel, we're going to talk about what the experience of individuals with FA have been. And having met with this group of panelists before, they have so much combined experience and expertise that I definitely don't have. So you're going to hear, I hope, some of the wonderful anecdotes that I heard, and some also very practical and concrete suggestions to help achieve more independence in managing care. So where we're going to start is to I'm going to ask each of our panelists to introduce themselves, tell us a little bit about what they do, where they live, what they do for fun, and then we're going to move into questions for each of them, and then also include you all. And we have a relatively small group, so folks should feel free to shout out even if before the formal audience Q&A you have something you'd like to contribute. So we'll start with you.
Alrighty. Hey everybody. My name is Aaron O'Neill. I am 42. I was diagnosed in 1992, so 30 years ago. So hopefully I have a lot to tell you. I just got married, got laid off. I'm sorry, I worked for 17 years, full-time in the hospital. Got laid off because of COVID, but it worked out because now I have time to work on me. And I just got married last October, and my husband's right there videotaping.
Congratulations.
And Ron Bartek was the officiant in my wedding. So that just shows how important FARA is to me. Yeah.
Hi, I'm Christina Cadoro. I'm 32 years old. I was diagnosed when I was 21, so 11 years ago. I am a daughter, a sister, a wife, and a dog mom of a puggle who's just turned 2 years old. What I do for fun is, I know I don't look it, but I like to go and eat, try different restaurants. And a fun fact is, recently my husband and I got to meet Robert Irvine, and he was so nice, and he took care of us, because he saw I had a walker, and it was hard to navigate through where we were at the restaurant, but it was cool that someone like him, I got to tell him about what FA is and what we go through as a community.
Hello. Yeah, my name is Liam Doherty. I had COVID about a month ago, so my voice is still recovering. I am 32. I have a wife and a 4-year-old daughter, and right now I work for the Department of Public Health in Philadelphia, and I used to work at the Center for Independent Living, and that which we'll get into later. And what I do for fun, I do improv, which is really goofy and not very serious, but it's a lot of fun, and I really recommend it to anyone who wants to kind of get out of their shell.
Wow, that's awesome. Thank you. So if we have time left over, we'll just listen to some improv at the end of our session. Awesome. And Erin, congratulations on your wedding. That's awesome. So we had planned a few questions ahead of time to get the discussion started. So Erin, we'll start with you. And our first question is, can you describe any issues or experiences you have had with medical care when transitioning from pediatrics to adulthood? Really anything, but we also included like medical decision-making process, access to your records, or anything else that you think was noteworthy during that transition.
So I had a story that came to mind. I was not going to share it, but Shana said it was a good story.
It's a good story.
So I was diagnosed when I was 12. I went to every appointment, I did what my mom and dad told me. I went to every doctor, and then I turned 18, and nobody really knew what they were talking about. This was a long time ago. So I stopped going to the doctor when I was 18, because nobody was telling me anything good. So I got a job at a hospital. So I decided to go see a doctor, a neurologist at my hospital. So I went and saw him. It was probably 2005-ish. When I went by myself, we did not have a good conversation. I think he told me that I had 5 years left and I was by myself. So I left the office, crying, and I had to go back to work. So I wasn't going back for a follow-up. So then I met Dr. Lynn in about 2009. And he was the first doctor that knew what he was talking about and was so hopeful. And he didn't give me a time frame. He just told me what was going on, encouraging. So ever since that, I've gone to Philadelphia on that 6 or 7 hour drive to see Dr. Lynch and his whole staff. They really changed my life for the better. So I make sure I see him every 6 months. 6 months. And I would never see an outside doctor. But things are changing. So I'm not telling people not to go to the doctor. I'm just saying things are different. And people know what they're talking about. And if you can't find one, go see Dr. Lynch.
Well, I appreciate you sharing that story. When we said it was a good story, I'm so sorry you went through that, but it's like incredibly illustrative, right? So you told us when you turned 18, like your folks had been facilitating and then you kind of fell off and weren't going to anyone for a while. So we want to avoid that for sure. You also went to someone that was not a good fit. And what we ideally do now, if you're transitioning either from peds to adulthood or to a new subspecialist, or if you need a new specialty involved in your care, the guidance suggests that we as physicians do like what's called a warm handoff, meaning we contact the new specialist, and then you go to the appointment, and then we may even see you once again after that appointment happens to see like how did it go. And if you had gone back and said like this person knew nothing, was ill-informed, like maybe then someone might have found someone else for you. So I'm glad it had a happy ending, and the takeaway of seeing Dr. Lynch being a great thought was a good takeaway too, but I appreciate you sharing that even though it was tough, because I think it was part of the motivation for a session like this one. All right, so next question for Liam, who also has amazing professional expertise in this area, so listen up to the answer in particular. Question is, when did you come to understand what your health insurance or other benefits do or do not cover? And like, how did you educate yourself on this? Big, huge question that you can just get started answering. What do people need to know about transitioning from their parents' insurance to their own insurance?
Yeah, thank you. It's funny they use the word education. So in 2015, I got my master's degree in public administration. It was right around the time the Affordable Care Act, Obamacare passed. And so we all kind of did a lot of research and reading around that. And I ended up being totally surprised by health insurance and everything. It was even then, even after getting my master's, so beyond me complicated. I broke my toe in school, and it ended up being kind of several years of recovery and bone stabilization and stuff. Over that time, I started working full time, and because of the complexities of healthcare and Medicare and Medicaid, I lost my Medicaid coverage. I will kind of go more into this later also, but there's sort of peculiarities, if that's the word, of having Medicaid and working full-time, getting off SSI, SSDI. I don't know if you're who gets that, but you generally cannot work and be on Medicaid at the same time. They're not total differences there, but anyway, so I broke a toe, and then when I was on Medicaid, it was paying for it was fine. I had no issues. Everything was free, pretty much. And then when I lost Medicaid, I was so surprised by the cost of everything. I had to like cover co-pays all of a sudden, and a bunch of other costs for X-rays, and so it was really kind of shocking. I mean, the system is just so complex. I really recommend just reading all the mail that you get, even though it may seem kind of above your head. That's kind of the main way that Social Security gets in touch with you. Through mail, that's really the only reliable way. I would recommend that as far as education. Maybe just that. In terms of like being covered under your parents, I think it's 26 years old is like age out now. But even there, it's kind of like state by state. I believe that there's some variability, but Cliff Notes is that it's really short. It's really complicated. Very complicated.
So thanks so much, Liam. And I feel like we've heard from our patients different anecdotes similar to yours, that like I was in one way and then I either moved or I got a job or I got older or something happened, and then broken toe, whatever else it was, that then there were some surprise medical bills generated. And we're going to keep talking as we go about resources. We were challenged in preparing for this event that like each person's circumstance here may be different. You live in a different state, you're different age, you may or may not be employed, but there are some common resources, including the Got Transition website that I shared, social work teams at the clinician, at your appointments where you go. There are some folks who can like help with orienting you, but and I like the read the mail advice to make sure that as things change that you're getting a chance to hear about it. And being aware of all these issues really is part of what we wanted to accomplish with this session. So next question on this list for Christina, and the question is, who accompanies you to medical visits now? And is this different from when you were younger or first diagnosed? And follow up to that is, if you've been accompanied by your parents or caregivers in the past, did the healthcare providers talk to you, or did they talk to your parents or someone else or caregivers? And if they did talk to your parents or caregivers in the past, how did you come to be the point person in your clinic visits?
So I was diagnosed at 21, but I started noticing symptoms at 17. And from that time, I was away to college 5 hours away. So each break that I would come home, I would go to different doctors. It took 4 hospitals to figure out what was wrong with me and what I had, and I was finally diagnosed at Johns Hopkins, but then he referred me to Dr. Lynch in Philly, so I've been going there since. But my parents have always come with me, and they still do to this day. And I think Dr. Lynch is great about making the patient the point person and asking you if you have questions first, because you're the one who's going through everything. And for advice that I have, if you are going going with your parents is to make sure you have that conversation first, because what your parents are seeing may not be the same thing what you're feeling and going through, or not seeing what you go through every day. So just having that conversation prior and coming up with questions together.
So I really like that advice. I think it bears repeating that. I think, Christina, when we were preparing and you said that you would talk ahead of the visit sometimes, or you think about talking, you'd recommend folks talk ahead of the visit of like who's going to cover what topics, and if you don't have a clinician like Dr. Lynch who makes sure to engage you, whose perspective may be different than the folks you're bringing with you, how to redirect that person towards you. You know, as pediatric providers, we're taught to try to do this early on so that you develop those skills in a developmentally appropriate way, right? A 10-year-old can advocate for themselves and can start to learn to do that, and in a graduated way, they can acquire more of that practice. You look like you had a thought. No, okay. But actually, that was great, Christina. Our next question is, Aaron, for you. And this, I feel like, may be the subject of another. You have a wealth of rich anecdotes, Aaron. Can you give an example of when you have had to advocate for your medical care because you were with a doctor who was unfamiliar with FA?
Yes. So, like I said, I used to always go with my parents, and I was 12, so I didn't really care or understand anything. I was a little kid. Now with Dr. Lynch, who is great, he'll talk to me. But I recently went to an urgent care clinic because I had a blocked ear. And Matt was with me. And people usually talk to him and not me. So when the doctor came in, she didn't know me at all. And I understand how I sound. So I said to the doctor, just before we start, I want to let you know that I don't have any cognitive impairment. Like, I understand how I sound. You know, people think, they assume we're slow because of our speech, but once I told that, she was good, just directed me, and so it was good. So it's important to stand up for yourself and understand how you appear and how you sound to other people, and don't get mad at that. Just, what are you gonna do? Like, if I saw somebody that spoke like I do, I'd probably speak a little slower too. But making sure you tell them there's no impairment and really seek help.
Thank you so much for that. So when we first were talking about this question about who gets spoken to, you know, the issue of doctors speaking only to the adult is common to folks with FA, but without FA, with other, because, you know, doctors forget to address the young person. But the suggestion you made, you know, how the speech differences could impact, you know, people's assumptions about intellectual capacity, and like a lot of courage that you had to just like get right out ahead of it so that you could make sure your needs were articulated directly. I think that's pretty remarkable, and another really very concrete suggestion to folks who haven't thought about it, especially in like an emergency room setting where people may not be familiar with the condition at all. Liam, I'm looking forward to this question because this came up as a kind of resource that folks may not be familiar with, that we want them to be. And we're lucky that you have a history having worked for a Center for Independent Living. So we wonder, can you give us an overview of what that is and what type of resources that kind of a center can provide for someone living with FA? Also, where are these centers? Is there one in every state in the U.S.?
Yeah, so, excuse me. So Centers for Independent Living are across the country. There are over 400 of them and they're federally funded, so they're partially public, and so there is one in your area. I would recommend just Googling Center for Independent Living and then your zip code or county, and that should pull something up. They're advocacy centers. They have like a bunch of core services they provide, but sort of most important to this session is transition services. So it includes the kind of transitioning from nursing homes to living independently, but also just transitioning from being a youth to an adult. And so I really recommend reaching out to your Center for Independent Living, and they could kind of coach you on the specifics. If insurance change and benefits change, they're really valuable that way. They also, most of them hold classes around the good ones at least. So again, I recommend looking in your area, but they hold classes in like finance, and the one in Philly even does like they have a kitchen and do classes on the cooking, but managing personal care attendants if you have an attendant. There's so many things that come up as you transition to an adult. So they are so valuable, and I think that was pretty.
Yeah, that's really helpful. And I recall, it may be one of our panelists or someone else who was speaking. You had an experience with the Center for Independent Living too?
Of course, I have a little. So I go to the Boston Center of Independent Living, and they provide me with my PCA care. So I never heard about it until after I stopped working. So they came and evaluated me, and right now I have like 40 hours of care or something. But when they first came 2 years ago, I immediately got like 30 hours or something. And the woman said to me, "Why didn't you do this sooner?" So my advice is, if you don't need a lot of help right now, get in with the Center of Independent Living so that each year they get reevaluated. You can get more hours as you need more, but start when you don't need them. That's my tip.
I love the tip. They're accumulating. Yeah, so identifying those centers early so that you know what you're eligible for and then continuing to revisit that. I think that's fantastic. Next question goes to Christina. Christina, can you describe some of your experiences? I think you may have used the word adulting. Someone did, but like finding an apartment, navigating public transportation, requesting employer accommodations, really adulting. Yeah, tell us more.
So I recently lived in Philadelphia, but moved with COVID and everything. But when I was living there, during the time, I did not seek out any apartment questions with disability because I was still at the point where I didn't need that. But I did rely heavily on public transportation. So in Philly, they had a program. If you had a disability, it was $1 a ride versus a few dollars. I forget what it was. But that helps because, as we all know, living with a disability is very expensive. You always find yourself in a situation where you didn't know what's going to happen. And then same with medical devices, just doing your research. And I recently got a scooter, so looking into resources and different companies, what works best.
That's really helpful. So the public transportation funding, like early on, so it's terrific. So then we have a few more kind of general questions for the panel, and then we'll open it up to more from the group. So these are some questions that I had thought about because they come up with our patients. One was, do you know how to reach your medical care team, in particular if you have an urgent question after hours? Like, so when the office is not open, like, do you know how to reach them overall? And then, like, what about on the weekend or at night? And anyone can field this.
Yes, I can start us off. I recently started going on to the online portal for my healthcare providers. And, you know, it's really been so valuable. I mean, many people probably have Dr. Lynch who responds to emails, you know, on Sundays. It is amazing anyway, but not every doctor is. And so, yeah, I really recommend online portals. I see a doctor through Penn and Jefferson Health, and both have online health sort of portals, and you can e-message your doctor there, and usually within a day they'll respond with kind of non-urgent medical questions. If you have, I reached out to my cardiologist recently because I was sort of wondering about a certain thing, and you know, the portal even let me take pictures of pictures of my foot because it turned a certain color, and I was like, this does not look good. So I took a picture and attached it to my email or the e-message, and then, you know, yeah, within 24 hours, my cardiologist got back to me and said that the color was okay. Yeah, I really recommend that.
My answer was I have Dr. Lynch on speed dial. I don't think they like that answer.
We love that. I mean, you know, although, so this is the online portal for like non-urgent, but like between visits, or you kind of need the answer, but you know, you want a more efficient way of getting to someone. I love that. I love trying to reach Dr. Lynch too, except for sometimes you're concerned maybe not neurologic, although he's super knowledgeable outside that too, isn't he? From an endocrine standpoint for our patients with diabetes, like, and I think this would be true for your cardiology practice or others, there's an on-call team 24/7, and you can page with urgent questions, and some people, hopefully most people, specialists would have that, but I would encourage folks to ask at your visit, like if you're seeing a specialist, like, hey, if we have a question, you know, between visits, do you have a portal where we can upload that, or do you have an on-call team who can address urgent questions, so that there's something between, you know, doing nothing or hoping Dr. Lynch is going to answer as quickly as usual and going to the emergency room where, you know, to be avoided if you don't really need it, right? So we want to make sure folks feel like they have more resources there. So last question for the panel, actually related to emergency care. And I think, Christina, you may have had a tip, but we may start with you on this one. So if you need emergency medical care, like if you were going to an urgent care or an emergency room, either with or without your family present, would you know how to share all of your information, like what are your health problems, what are your medicines, your insurance information, that kind of thing? Do you have that in one place, or how do you communicate it? And if there are folks unfamiliar with FA, beyond you know, being told about the fact that folks can communicate for themselves, like how would you share more information about FA? So I feel like you told us something that I thought was helpful.
So I was away for college when I was diagnosed, so I had two tips. One was a medical bracelet, just so other people can know if I ended up having to go to the hospital if something were to happen. I would have like my emergency contacts on the back, what FA is, and the main source, like cardiomyopathy. So I had that, and then I also carried around a card that in my wallet what FA is, because I was 21 and wanted to go out to the bars. So just so people knew I wasn't drunk or anything. So just having that, even not doing that, going out to the bars. I don't want to make it seem like it was just for that, but just to always have that information because not everyone knows.
Did you have something to add?
When I was 21, I was also getting kicked out of a lot of bars. So I had a little National Ataxia Foundation card. I had it laminated so it looked official. And that's how I would get into bars. Not go home crying.
I think I would say also that, you know, there's sort of like an existential part of this too, or like sort of a deeper part that, you know, I think transitioning from, you know, being, you know, having your parent sort of as this like round the clock advocate to like be able to communicate to your health providers sort of about yourself and not having that lifeline. I mean, I'm sure the parents, you know, still exist, but they might not always be around for the rest of your life, and so I would, you know, maybe the deeper point that I'm getting at is understanding what you need and what your body is like, the specifics of your medical care, having like literacy around, you know, the things that you need, so you can communicate with, you know, an urgent care provider on sort of the intricacies. You know, I'm saying that as somebody who does not know everything, and you know, and definitely after today, you know, just that so much of it goes over my head as a layman. But you know, I think I would say kind of a educating yourself, advocating for yourself starts with understanding yourself, and being able to live independently, and yeah, I don't know. I feel like I'm on a soapbox now, but does that make sense?
I love your soapbox. So we started with talking about the emergency room, and we went quickly to college and existential thoughts and bars. And so, you know, these discussions extend well beyond. To add, just for preparations, like some of our patients with diabetes or some with other complex health conditions, some people carry like a piece of paper summarizing, you know, their meds or their health conditions. And as you know, Jen introduced earlier this morning, the updated care guidelines will be around soon, so providing a link to those, because folks who are unfamiliar could refer to those, and that's hopefully going to be an easier to navigate resource too, so adding to practical suggestions. I think we have a little bit of time left in the session, right, for anybody to, I think I'd encourage you to ask questions of our awesome panel, because they're far more knowledgeable in the practicalities of navigating this than I am, but or points that people may want to make their own stories. We welcome them.
So the services start whenever, you know, the under 18 you know, and if yeah, you know, I mean, medical insurance is such a can of worms. But Centers for Independent Living work on transition specifically. So they're federally funded to help people who are under 18. So if they don't, they should be. And yeah.
There's one in the back.
Hi, I'm just curious, do any of you guys have a spouse or a parent that functions as a personal representative for you guys? And if they do, what does that relationship look like? I may not, the term might be different. Basically, somebody that is able to make medical decisions on your behalf if you're not able to, or any of that ringing a bell?
I have that all written down in a mulch form. Kind of a mulch, like a Massachusetts. All my decisions are written down, and my mom is my mom and Matt are my healthcare proxies, so I would assume.
Yeah, no, whatever answer you have is valid. So it sounds, you know, the personal, or people may use like healthcare proxy or power of attorney in different contexts. So just as you say, sometimes you may anticipate a circumstance where you may not be in the position to make your own healthcare decisions, and so how have you anticipated that? It sounds like, right? And so for you, you have your mom and your partner who are both in that role, who can like make decisions on your behalf.
And I have it all written down, so.
And so getting it all written down.
They don't really have to make any decisions. They just have to read.
Just for clarifying, so there's the writing down of like who those people are, right? Like, yes, this person is can serve as my healthcare proxy, et cetera. But it sounds like you've gone further to articulate kind of what your preferences are. Is that right?
Yeah.
Oh, okay.
Yeah, like not in DNR, but like I forget what it's called. But in the, to resuscitate you. But after a while, like, I don't want to be in a machine forever. Try your hardest to do the work. And then you can pull the plug or whatever. It's all written down.
So it sounds like you've had those important conversations about what your preferences are and written them down to try to help your healthcare proxies should that circumstance arise. Yeah. Does anyone else, is that what you were getting at, sorry? Yeah. Does anyone else want to share their experience?
Thankfully my wife is a nurse. I graduated in, sort of a nurse practitioner as of yesterday, so yeah, I'm hooray for her. But yeah, and I don't have much experience in that.
Let's think about.
Yeah, something to think about, to have articulated for sure. Especially when you're turning 18, right? Because then the default goes from your parents or caregivers to whomever you've designated. So important to have those conversations.
I would just add, as a systems issue, if you do have a durable medical power of attorney, or a power of attorney in some other fashion, or advanced directives, it's really important you let your healthcare providers know that. Because if they don't know that, it's essentially an unknown to them. So those are really great documents to have, like very forward-thinking, very forward-looking, like very, very important stuff to have. But it doesn't mean much if the hospital system you treat with or your providers don't have that. And then there's also some advice, and I don't know what it would be, about how to have that in play if you are out of your jurisdiction and have to go to the emergency department. So if you have informed your local hospital system, the emergency department you'd go to should know about those, durable medical power of attorney, the advanced directives. But if you're traveling or something along those lines, I don't know what best practices would be in terms of making sure those documents travel with you. if anybody had comments on that, I'd be interested to hear.
Practically speaking, I mean, this is usually outside the scope of what we do in pediatrics, but we do care for some folks that are over 18, that like when you're outside the typical range, it seems very old school to have like pieces of paper, but like if you have a binder or you have, and a binder is comprehensive so the ER folks can't like go through fast, but if you have something concise, it's like one page about the history and copies of those documents, like those would be potentially very important. But making a really great point that like those preferences that you've articulated and the decision-making power, you know, needs to be made aware to folks. So thank you for that. Is that time? If this timer is accurate? Yeah. Oh, I think there's one more.
Oh, boy.
All right, one more question.
Yeah, Aaron, just how many bars were you thrown out of?
Thanks, Dad. Nice question. I actually wouldn't get thrown out. I wouldn't get in.
That was my problem.
All right, well, thank you, everyone. Yeah.
Thanks everyone for coming.
Okay, so we have 15 minutes until the second round of breakout starts. So everybody has a few minutes to hang out, and we'll wait for the other rooms to finish, and then you guys can move on to whatever one that you want to go see next. So over there is emotional health awareness, and then down the hall on the right will be advocacy, and they might be finishing up, so definitely give them a few minutes to finish up, and we'll rotate through.
Yeah.
What do you think?
Oh.
Okay? Sure. Just like we practiced.
Oh.
Yeah, not bad.
Absolutely.
Sitting for a second. So you wouldn't get into the bar, huh?
No.
And did you have bar issues?
Bar is.
Like not getting into bars?
Oh, yeah, I mean, it's,